Let's talk about the first item underneath our diagnostic category, which is a biopsy. Now, a biopsy is our most accurate way of getting a diagnosis for your type of hair loss, but it is not the end-all be-all, so we should talk about the risks and benefits of it and whether it's something that suits you. So number one, what is a biopsy? A biopsy is actually a skin sample that contains your hair follicle and the surrounding tissues. It helps us look for histological or cellular level causes of your hair loss. We could be looking for markers of inflammation, markers of the blood vessel getting miniaturized, anything that can help us understand the cause of your hair loss. Now, when we do biopsies, we do them in pairs. We take two to 4 millimeter circular punches that are about the fourth to a half the size of an eraser tip out of the areas where you have hair loss. Usually one in the area of greatest hair loss and one on the leading edge where the hair losses continue to grow. So we can see if they coincide and whether there is actually activity on the edge itself. This is performed in my office by myself. We numb up the area. We take a punch using a circular blade. We take out the tissue. We suture that area closed such that the hairs on all sides of the biopsy come back, touch each other, such that you don't have an area of hair loss in that spot. We send that tissue off to the laboratory. It's read by a hair loss specialist, dermopathologist, who looks at this at a histological level. Now, they will usually reach out to me and ask me clinical questions about the history of hair loss or pictures of your hair loss if they can't get a straight, concrete diagnosis histopathologically. However, I usually let them try to get their diagnosis first and then provide them with information to see if it links up. We'll get the results back in about 10 to 14 days. I will read them, interpret them myself, correlate them back with your clinical history, and we will discuss if we have information that helps your treatment plan. And that is the reason we get a biopsy, whether it's going to affect your treatment plan. Now, when you come to my office, you often give me a clinical history of how you had hair loss, how long it's been going on for, whether it's been shedding or no shedding, whether there's a pattern involved, whether there's any itching, redness, burning associated with it. You give me this history that helps me understand what could this hair loss be based upon your description. I then look at your hairs and I look for reasons why you're having hair loss. Do I see a pattern here? Is it female pattern, male pattern, or is there a global issue? Are there patches? We might go underneath the microscope that we have in the office called a trichoscope, looking for morphological changes of the hair shafts and the hairs as they emerge out of the scalp itself. And I can often make this diagnosis in the office, I'd say about 90% of the time, based upon your clinical history, your exam, and your trichoscope evaluation. However, in 10% of the time, those things don't link up. Something you say about your history doesn't match your clinical exam or your trichoscope, and a biopsy can really help us understand what that next step and what that next information is, so we can actually make a change in your treatment plan. We wouldn't go about a biopsy if it wasn't going to change what we were going to do, in my opinion at least. Take, for example, a woman who is having hair loss, but is not done having kids yet and is not near us. Well, if they have a hormonal type of hair loss, it's actually a big deal to know because we don't want to put them through hormonal treatments, not knowing what the research is on putting someone on medication like dutasteride prior to having children. However, if you're beyond menopause and family planning is no longer an issue to consider, well, yeah, we can actually put you on dutasteride, a hormonal medication, and we just have to see how the other side effects do, not so much more family planning. And we don't really need a biopsy at that point. Instead, we might be able to start treatment, see how you respond to treatment. And if you don't respond to treatment, we'll then get a biopsy to understand why treatment didn't work. Are we on the wrong course? Did we miss something? What's the clinical picture and everything to drive us in the direction of the wrong diagnosis? And a biopsy would actually put us on the right track. So a biopsy tends to be a very good answer for when there's confusion or when treatments really aren't working. And I would say about 10% of my female clients I recommend a biopsy to right off the bat. Another 10% who don't respond to the therapies around the third session of ACS. I'll see if a biopsy is necessary. And male clients, it's extremely rare. We know that about 98% of men have a clear-cut, androgenic, male pattern hair loss, and we're not going to need a biopsy. But there are some occasions where we do get them. So let's talk about the recovery from a biopsy and the risk involved. These are very small holes. You are tender after you have them because the skin is being sutured back together. You have to be a little careful. If you give yourself about 2 days where you're not washing your hair with soap or water, just letting water drip over, it's fine. You have to listen to your body when you're in the gym. Don't exercise too much, feel throbbing or burning. Just kind of calm back a little bit. These are 2 to 4 millimeter holes. They are very small. And you just want to listen to your body and let them heal. We try to put them in areas where they're inconspicuous. I did mention that a biopsy is best taken where hair loss is greatest. However, if the hair loss is in around your face, we're going to be a little cautious. We're going to kind of creep back into the hairs. We're going to take a little chance. We're going to take a biopsy in an area where it can be hidden, but we can still get the diagnosis. The risk of a scar being seen down the road is very low because we choose the area where the biopsy should be taken. I will warn you if this biopsy could leave a scar, an area where I'm concerned. Overall, the risk of the procedure is pretty low, whereas the benefit can really change how we're going to go the course of treatment. And if you fit into that category, 10% of women in the beginning, or 10% around the third session, or very few men, I will recommend a biopsy because I think it will actually help. I will not do it otherwise.